Hey, welcome everyone. Thank you so much for joining us today. My name is Christina Lively. I'm the program manager for the Master of Medical Sciences in Global Health Delivery program. And I have a slide up that shows today's panel. Joia Mukherjee, our program director, will be introducing the panelists. But I'm just going to tell you a little bit about the Master of Medical Sciences in Global Health Delivery. It's a 2-year master's program that prepares people to become leaders in global health, like the people you will hear from today. We study courses in research, research methods, program design, management, and we actually, it says applications are open now, but our application just closed for the class entering in 2023, but we will open that again in September 2024. So we are celebrating the 10th anniversary of the MMSc-GHD program. You can see last year we had a bunch of alumni come, and very exciting to have the 10-year anniversary. Our alumni are all over the world doing amazing work, like the people you will hear from today. And I just wanted to let you know we have a series of these panels. So the next panel is going to be on women's health. It's coming right up Friday, February 3rd. And if you are here today, you may already be on our email list, but if you're not, you can get on our email list and then we will remind you about the upcoming events. We're planning to have a panel each month up through May. So with that, I'm going to turn it over to, actually, sorry, I'm going to do one more thing, and that is I'm going to let everybody know about the format for today. So this is again, a panel discussion. We're going to have each panelist speak for 10 minutes. And again, the topic today is the COVID-19 response. So these alumni will be talking about their roles in their respective countries in the COVID-19 response. They will speak for 10 minutes. And then at the end, we will have time for questions and answers. For those interested in asking a question, please use the Q&A function that you will see at the bottom of your screen. Those questions you type those questions in, and then we will, here, I'll just stop this for a second. Type the questions in, and then Joia will look through them and ask some of the panelists. Panelists, you are also welcome to type responses to the questions. If you see a question that looks like, oh, I can answer that, you're welcome to type the responses. But just to note, we will be holding all questions until after all of the presentations, just to make sure we get through all the presentations. Okay, so with that, I am going to turn it over to Joia. Yeah, Joia.
Great. All right. Well, thank you, everybody. And, I love to see this panel of very strong women from different places in the world. And I give Christina Lively a lot of credit. She's always making sure that we have women. As many of you know, women hold up the world, and certainly it's true in global health. And yet it's often harder for women to participate in such a program because they have family responsibilities. So thanks to Christina, we always have at least a few. And the other thing I want to say is, none of these three amazing leaders had worked in COVID, nor had they really worked on pandemics. But I think what we learned from the Masters in Global Health Delivery program, from the work in global health delivery over the last 20 years, and from the work you will hear about, is that what allows you to respond to a pandemic is having a health system. It's not some thing that you just parachute in, a pandemic preparedness. And so what we've seen around the world, and we're so proud of, is that so many of our graduates who studied maternal health, like Elsie, who studied insurance and maternal health, who studied migrants, like Lisa, or insurance and maternal health, like Phenide, they were tasked to look at COVID and support COVID because they understood the system itself, and they understood health inequalities, and they understood the vulnerability that certain people have. Because remember, in this pandemic and any other, it's always the poor and the marginalized who are the most affected, whether it's by the disease itself, because of having illness, underlying illness, by the risk for disease from, mal-distributed social and economic resources, or by the impact of things like lockdown. And so what we always hope is the focus on delivery of care and building the health systems is truly pandemic preparedness, not a pandemic preparedness as a standalone study. So I'm just so proud of all of these three amazing graduates. I know I've learned a lot from all of them. And so we're really looking forward to hearing from all of you. And we're going to start with Lisa Parvin.
Thank you, Joia. Thank you so much for the encouraging words and the nice introduction. So for the interest of time, I'm going to share my slide deck and let's see. So I hope you can all see it. So it's been an honor and privilege to be part of this program and also this part of this panel. I'm looking forward to sharing some of my experience working during the COVID-19 pandemic, which is not quite over yet in my view, and also looking forward to learning from my fellow panelists. So before I move on to my topic for today, I would like to add that I graduated from the program in 2019. And part of my program, I worked in my master's thesis, looked into accessibility to routine vaccination programs by ethnic minority group in Bangladesh named as Bede. And these are the nomadic group that we have, traditionally nomadic group, but most of them now have been settled in the recent years. And this is one of the villages that I worked in Bangladesh. So before I move on, I would like to quickly give a shout out to my manager, Samantha Tong. I got some of the content for today's presentation from one of her presentation in March 2022. So I was working with Fraser Health during the COVID-19 pandemic response. So Fraser Health is one of the regional health authorities in British Columbia, which is one of the provinces in Canada. There are 5 regional health authorities, and Fraser Health is one of the most densely populated one. As you can see, it's a much more smaller in size, but it has the most diverse population. So most of the immigrants, refugee populations choose to reside in this area. And the largest community that we have among the immigrant groups is the South Asian immigrants. So about 75% of BC's South Asian communities actually live within Fraser Health. So in 2013, we established South Asian Health Institute with the goal to really understanding the key health issues of South Asian populations in Fraser Health area, and also to support developing culturally appropriate strategies to improving their health. So what SAHI was already doing before pandemic was they had a good network and connection and partnership built within the South Asian communities in the region, and also doing a lot of health promotion. But then during COVID-19 pandemic, we quickly shift our focus to COVID-19, as many of us did. So to give you a little bit context about what was going on, so towards the beginning of the pandemic, we quickly realized that large multi-generational and overcrowded households were getting more affected by the disease burden. And also there were large workplace outbreaks. And in those contexts, the majority of the households and the workplaces were predominantly represented by racially diverse backgrounds. But yet there was a delivery as a gap in the services, because the health Joia mentioned, health system, we were able to identify gaps because there was a health system existed, but we quickly realized that the health system was not working for all. So it was designed for English speakers, and there was a lack of safe space, available resources in different languages, and the pandemic messages was changing. The public health order was changing by days, if not by the hours, and we kind of realized that there was a gap, and it was affecting disproportionately people who had high burden, and as a result, it was affecting the case and contact management, and as well as effectiveness of broad public health measures. So that's the context. So going into the pandemic, SAHI already had some strength. It had established connections, but we rapidly increased that too by many-fold. We got many more volunteers and team members came on board who had they had fluency in different South Asian languages, connections. We partnered with different places of worships like Gurudwara, Mandir, Masjid, different ethnic businesses, wedding vendors, different community-based organizations. And we were really able to leverage those connections into delivering COVID-19 responses. So our team, we had a dedicated outreach team of 4 program assistants and 40 volunteers. So I will focus on, so we did a lot of work in health literacy, knowledge translation, like translating the public health order in different languages, and used our community outreach team to really reach to the communities and inform them how to keep themselves in safe during the initial days of the pandemic, and really help our partners to implement some of the measures that were in place, like help the places of worship to follow the PHO orders, for an example. But we also provide a lot of system navigation support. So as you know, we do have a healthcare system, but unfortunately, the system can be very complicated and fragmented. And for someone new to the country, or for someone who might not be fluent in the language that the system uses, is that easy to navigate all the time. So we did provide a lot of support and one-on-one support when we were able to go to the communities. We did a lot of in-person outreach and also cold calling, just calling up people and talking to them and walking them through the responses, the available care that were available for them. So for today's talk, I will focus on a little bit about SAHI's work in vaccine delivery. So what we did, we leveraged on our connection with the community partners and organized in-reach vaccine clinics. So instead of bringing people to the vaccine clinics where they may not be familiar with the system, we actually partnered with our community leaders and community settings, and we organized and supported in coordination with the vaccine clinic, really, so that people can have their vaccine and remove some of the barriers that we were seeing happening on the ground. So for that, we were really able to harness the strengths that the South Asian communities already had. So there was willingness among the community leaders and also the community partners to promote COVID-19 relevant information. They were willing to host the vaccination clinics for their community members, and community members trusted them, and they were already familiar with the location of the clinics. So we ended up going and having these clinics at the backyard of different places of worship when it was allowed for people to come and meet at those places. So We went to gurudwaras, masjid, temples. We went to neighborhood pharmacies. We went to different business establishments where predominantly South Asian community members gather for their shopping. So we really brought the vaccine to them, in addition of having the system already in place for mass vaccination. And that really helped in our view, because so this is just a stat between mid-May and October. We organized 29 in-reach vaccination clinics, and about 7,000, over a little bit over 7,000 community members got vaccinated. We also provide tons of support about registering them into the provincial government system, which is also designed by English speakers and is a little bit technologically challenged. And in our South Asian communities, we do have lots of elderly population living there who didn't quite know how to use the smartphone or any kind of computer, basically. So we provided a lot of support in the languages that they understood, in a manner that's relevant to them in the places where they were visiting any house on a weekly or daily basis. So what this enriched clinics did is removed some of the barriers that we were observing. So it removed the language barriers, transportation issues, technological divide that we were seeing. And also it addressed some of the concerns around the concerns that undocumented and migrant workers had. We minimized some of the anxiety that they were having. Seniors, we saw that seniors, even though they were eligible to get vaccine from the beginning, but many of them were more comfortable coming to their places of worship and having it there when we started offering them. And truck driver, one of the group that was having, from the beginning of the pandemic, we were reliable on truck drivers in so many ways, because all of for our goods to cross the border between US and Canada. But because of their schedule, it was hard for them to come to a mass vaccine clinic and get an appointment and a fixed date and time and take it. So this in-reach vaccination clinics were offering walking accessibility for them. And in addition, we also provided, as I mentioned, a lot of health system navigation support. So after our success of our expanded connection with the communities, we till to date, we kept the community outreach team, and we continues to do health promotion like before COVID-19. Health and nutrition is an important topic that we work on. We keep on creating awareness around different health issues, including COVID-19, vaccine booster dose, children's pediatric vaccine. We continue to do health system navigation support, but one focus that we expanded using this community in-reach model is mental health and substance use. Because in British Columbia, we've been having overdose crisis for past several years. It was announced pandemic since 2017. So we expanded our focus to that and creating awareness around mental health and substance use among the South Asian communities living in Fraser Health. We are also developing a cultural safety training for healthcare providers because, there are, unfortunately, there are bias in the system, and there needs to be cultural sensitivity when it comes when patient comes to accessing the healthcare, so they feel safe and welcome. We also expanded our targeted approach for the most vulnerable groups, which are migrant and undocumented workers, refugee populations, and international students. So for this slide, I wanted to focus.
And Lisa, you're just going to need to wrap up. So
yes, Yeah, so that's what I was going to say. I would love if there is time at the end of the our panel discussion. If anyone interested, I can come back and focus on how my training in global health and social medicine helped me to work in a system which is one of the best system in the world, perceived as best, and how I was able to still utilize my training in here. Thank you.
Thank you. Thank you so much, Lisa. That's just wonderful to hear about. And, you know, so many of the things you talk about are really related to things we see all over the world. And you're right. You have wealthy countries like the US and Canada, and we can't manage. And in fact, many countries did far, far better. So I think next we're going to, sorry, I lost the chat. Who's next? Elsie, and we'll go to Dr. Elsie Ballah, who's now the director of the Liberia Health. Tell us what the name of it is. I could just call it the NHL, but and Elsie will.
The national. Okay, so good. Can you hear me? Good morning and also good afternoon wherever you are. Thanks, Joia, for allowing me to be a part of this forum, and thanks, Christina. So I'm Elsie Ballah. I work, sorry, let me share my video. Okay, so I work as head of the maternal and child health research team at the National Public Health Institute.
Can you put your slides in slideshow mode? Just go up to slideshow.
Sorry.
That's no worries. And then do play from start.
Okay.
Over in the right-hand top. Whoop.
Oops.
Your computer is touchy, Elsie. No, I think you want this, go down a little bit. No, not that. No. Bailey, do you? It's okay. Bailey, oh, okay. No, go down. It's the one in the corner. Yeah.
That one. Yeah.
Yay, there we go. Okay, awesome.
Okay, can I go ahead? Sorry about that. Hello?
Yes, go ahead.
Yeah, go ahead,
Okay,
please.
so, thank you very much. So I'm Elsie Karmbor-Ballah. I work as the lead for the maternal and child health research team at the National Public Health Institute. I also do a little bit of clinical research at the Partnership for Research on Vaccine and Infectious Disease in Liberia. That was a partnership that was created out of Ebola, that's PREVAIL. So I work also as a part-time site physician at one of the sites. I also co-teach at the University of Liberia Public Health Program. But most importantly, I want to share that I'm a 2018 graduate of the Harvard Medical School, the MMSc program. So knowledge from that program that has to do, and I want to stress a little on the biosocial research, also in management, and then in program design. Those were knowledge and skills, I think, from there that actually keep me going in my current work, and also methods that I learned from there that I employed in my thesis program. So I did a mixed method study for my thesis at the Harvard master's program, looking at the exploration of opportunities and barriers to reduce maternal mortality in Liberia. So as I said, knowledge from that program also helped me with my current work. So what we do at the maternal and child health research team, as maternal and neonatal deaths come at a central point at NPHIL, we go to do further investigation to ascertain the circumstances surrounding those deaths. So qualitative skills from the MMSc program also help to shape my level of work that I currently do. And the program design also learn from there, help to put me on track in terms of serving as a lead consultant that was able to develop the national respectful maternity care strategy in Liberia. So for the COVID response, I would like to start a little by saying something on the health sector engagement. So in terms of preparation, as we know that there was an outbreak of respiratory illness, cases of respiratory illness that was later confirmed as COVID from Wuhan, China. And so other countries, including Liberia, began the preparatory stage by doing some level of preparation. So one of the first that was done by the health sector is to engage, having an inter-stakeholder information section. I was organized, and it was done to present the current status of COVID globally. And it was also used to lobby for funds from the government in terms of presenting the current state of the health sector at the time that will be able to lobby funds that will help the health sector to be able to prepare in the event of a positive COVID case. And so as that went on by the first week of March, there was the establishment of screening protocols at the airports. And there was also the establishment of the first precautionary observation center, that's the POC. And that is used, it was used to quarantine travelers that were returning to the countries, in the country from other, high-risk countries. So that went on by the 16th of March, we recorded our first confirmed case in Liberia. The next day, the second case was recorded, confirmed. And so within a space of 5 days, from the 16th of March to March 20th, we have recorded 3 cases. And due to that, it raised alarm to the health sector, and they declared a national health emergency on the 22nd of March. So in addition to the setting up of these precautionary observation centers, the 14 military that was located in the Mukherjee County, the Robertsfield Highway, was quickly set up as an isolation or treatment center. That's the C2, the COVID-19 isolation and treatment center. So this was not, quite set up until after the first case. So from the first case, as things and time went by, there was a lot of improvement in this center. And so shifting a little from the government to go towards the community, a lot was being focused at the community level in terms of raising awareness on the practices of IPC, as the infection prevention control, and trying to conscientize in social mobilization to conscientize the public in terms of helping to protect them from getting COVID. So focusing on mask wearing, setting up of more isolation centers, as a lot of travelers were returning, a lot of isolation had to be set up. So in terms of, so what I was really engaged in during the COVID response was for training. I coordinated and also facilitated sections of the training that was done. And the training was focused on the health workers. So knowing as the outbreak was declared as of March 16, upon having the first case, automatically the establishment of the incidence management system. So within the incidence management system, there are several pillars. The case management pillar was a part, and the training arm of the case management pillar was what I actually coordinated. So I reach out to partners as the IMS meetings are held and the gaps are being presented during the meeting. Partners, express their willingness and they come on board to be able to help. So those partners that expressed their willingness and came around, we reached out to them to be able to get the exact support that we needed to conduct this training. So a total of about 873 health workers were trained. All this was done as the TOT, training of trainers. So it first began at the national level where the WHO was able to sponsor 2 of the national staff. And so those were actually the head of the case management fellow and the IPC fellow. They were sponsored with DRC to be trained. And so upon their return, they were also obligated, or they were mandated to train the rest of the county folks. So upon their return, 35 national trainers were trained to be able to cascade the training down to the county. So at the county level, we're able to train at least, with the exception of Monserrado County, but each county we're able to train at least 1 health worker, be it or the screener or the officer in charge, or those that are in direct healthcare provision with the staff. So we're able to, based on the selection from the various counties and the list, refer onto us, we were able to train at least 1 person from each facility. And I said Monserrado is excluded because Monserrado has over 800 health facilities, and more than 50% of that are private facilities. So just few, a little over 50 members after the names have been submitted from the Monserrado County Health Team added on those from the other counties that were being trained. But within the rest of the 14 counties, there were 1 person at least from each facility that was trained. And so for the partners that expressed their willingness and able to provide support for those trainings, we begin first with the World Bank project. That's the Regional Disease Surveillance System Enhancement Project, has been supported by World Bank. They supported a total of the training for the total of 506 healthcare providers. So that also included the first 35 that I've talked about at national level. And within the 12 counties, at least each health facility had a health worker that was trained. And those are Monserrado, Bombing, Bapulu, Margibi, Grand Julia, River G, Maryland, Nima, Grand Cruz, Sino, Riverside, and Grand Bassa. So the remaining 3 counties were being supported by WHO, that's Lofa, Bone, and Cape Mount. So for the USAID funded project, that's the FHR 360, they were also helpful in supporting the clinicians that were providing care at the level of the treatment unit and also the precautionary observation center. And then later on, okay, so later on within the year, Africa CDC also helped to train about 34, but these 34 were mainly at the national level for the continuous cascade of the training. So a total, as I said, of 873 healthcare providers were being trained, and this was being coordinated and directed by my team. I was the one that coordinated, and I also helped to facilitate. I went in some of these counties for like Nima County, Sino County, and Riverside County. I was present in these 3 counties while also coordinating with the other facilitators from the various counties to ensure that at least 1 healthcare worker in every facility in Liberia, especially the 13 counties in Liberia, had someone in our stream. Thank you very much. So that was the focus of my work at.
Thank you so much, Elsie.
Thank you.
And I'm glad your connection hung in there. So important to think about partnerships. And I think one of the great lessons that we have really tried to promote in the program, and you used, is the way for governments, you work for a governmental agency, the National Public Health Institute of Liberia. The way for governments to have control is to really coordinate partners, because a government like Liberia, even if they put a lot of their global or their GDP toward health, it's still not enough. And if partners come in and do whatever they want, then you can't have a coordinated response. So, being able to sit at that government position and say, no, this is our country, this is what we're going to do with the money, and really coordinate partners, I think that's the way to success. I mean, until we can get countries like Liberia more money, at least to use it wisely. And just, we're so grateful to have you in that position, Elsie, in Liberia, where I also work. And, Liberia's response to COVID was far better than the United States response, far better. And as people like you at the helm who did that. And, I always tell the story. I left Liberia. I was leaving Liberia. I think I saw you, I saw Odell, I saw Joseph, I saw several of our graduates. And I was leaving Liberia in February of 2020. It was just at the end of the month, February 28th or 29th. And at the airport, when I came into Liberia, I had to give my phone number, my address, my temperature was screened. This was in February, before there was a single case reported on the continent. There were hotel rooms set aside. And then when I left, they checked off the information again. There was no testing at that time anywhere. And I came back in the United States, and it was just crazy. Like, nobody cared where you were. There was no tracking, and people like Lisa had to set that up on the back end. So, we see that the public health and global health delivery is going better in many places than in North America currently. So Phenide, would love to hear about your experience in Haiti, a country that has not only had to deal with COVID, but at the same time had to deal with enormous types of unrest, political problems. And interestingly, Phenide, your very research thesis was impacted by the ongoing unrest, even at that time, 6 years ago. And so, we'll love to hear how you were able to learn those lessons to help Haiti respond to COVID-19.
Thank you very much, Joia, and so happy to hear for the wonderful work my colleagues are doing around the world. Very quickly, I am from the 2016 cohort. And at the time of the pandemic, I was working with UNICEF as an emergency specialist, and I was responsible specifically for the development and implementation of the community component of their plan. So we're going to talk about that, and also background, give you a little bit of background of the situation in Haiti by this time, talking about the both strategies, so national and UNICEF. We're going also to talk very quickly about the coordination, so the work I did for UNICEF and in very close collaboration with the Ministry of Health of Haiti, and see the key challenges. And I hope I could talk very quickly about how this program influenced my work. So just as a disclaimer, the scope of the presentation will be, so the period of this presentation will be January 2020 to April 2021. So I will be more focused on, the national preparedness and part of national response, and talk about, the part of the response of the UNICEF plan with the focus on the coordination and community engagement. So when Haiti, the first 2 cases of COVID-19 were confirmed on March 19, we were facing a very, very complex socio-political context, with political turmoil, aggravated poverty, food insecurity, and then the health system was weaker than ever. And Cornell University also had share a grim forecast, of grim prediction for Haiti. They are expecting in just 3 months to have 20,000 deaths and at least 80% of the population that will be infected by the disease. But the Ministry of Health very quickly started preparing the response that was since January 2020, so almost 2 months before the confirmation of the first cases in the country. And UNICEF also, since the beginning, confirmed its support to the government, to the Haitian government. So by the beginning of February, the national plan was already set with the main objective of avoiding the introduction of COVID-19, if that was possible, if not to limit the spread, to reduce the impact of the pandemic, including on other programs, because we wanted to have the other program run, keep running, and not having the side effect of this pandemic on them, and inform the population and train as much as health professional possible. And this plan also had 3 strategic pillars, so the surveillance, the patient care, and communication. And it's very important to mention that they also very quickly set up the surveillance, especially at the border areas. And all of this with that, not any kind of funding from the partners. And so what the government did was trying to reuse the existing resources they had, making an rearrangement of the existing resources. And so the UNICEF strategy was aligned with the national response, and with also 4 areas of intervention: coordination, communication, community mobilization, and awareness raising. And so what we did at UNICEF is that we build up on the existing cholera experience. Just for a matter of context, so Haiti, since 2010, had a outbreak of cholera. And by the time we had the pandemic, the COVID pandemic in Haiti, we were about 2 years cholera-free, thanks to all the hard work of the government and all its partners. So what we did in UNICEF is just to adapt the response already in place to respond to the new pandemic. And what we used, the approach we used, was the alert response system, which is a strategy centered around the case. So any confirmed or suspect cases, we will deploy team, but of different profiles. So response team, surveillance team, communication team around this case, and we will see further what were their role and responsibilities, what were the intervention we did with those teams. All of this with the aim to stop the transmission in households and in communities. So yes, we build up we went from cholera to COVID and used all this experience and adapted the response. So my work focuses especially in the coordination and in communication in rapid response on the field. So what we used was, so I had to design the protocol, the plan, so the community component for this plan. And so what we used was an integrated approach with key elements. So that was human-centered, with community engagement, good coordination, very important. We learned our lesson or trying to learn from our lesson from the chaotic response we had from the outbreak in Haiti in 2010. So trying to have a good coordination between the several stakeholders intervening in the response, effective communication between all the team intervening on the field, harmonization of field intervention, and trying to have real-time access to information. We will see why further for the community responders, and case tracing, rapid response, and follow-up cases. All of these with the purpose to contribute to breaking the chain of transmission, to facilitate the community engagement, promote the acceptance, and reinforce the coordination among partners, etc. So the coordination, that was a key part of this response, but we did it already with cholera. So what we did was to support the MOH leadership, not to take over as a partner the role of the coordinator, but supporting them to be the leader of all the intervention. So we had because we have 10 departments in Haiti, sorry. So we have 10 health directories. So what we did was we already have it in place. So we supported the Ministry of Health to, reactivate all the cells crisis cells they had in each department. So we reactivated the crisis meeting, and all of this were led by the directories, by the Ministry of Health, with trying to have on board all the partners involved, so everyone will follow a same plan, and also we will make sure to coordinate the intervention on the field. So usually doing this intervention that they were at the beginning of the pandemic, they were daily. And so what we used to do is that the situation analysis and very quickly planning the activities for the day. And that will, because we didn't have a lot of resources, so that approach helped us to have a better use of what we had, but most importantly, to avoid what we used to have in this country, duplication, and with the consequences we know. So that was the scheme we used. So the health department coordinating all the partners, all the response with our support among other partners. In terms of community engagement, so again, there were several organizations, local, international, all of them, they have their team, so different kind of teams, surveillance team, response team, communication team. What we did in cholera is we had a mixed team. So each team had, MOH members and NGO members, that they work in a complementary way. So we had also a very close collaboration with, all of the team in the field. It was very important, for example, for the response team to have a feedback from the surveillance team. Actually, they were receiving numbers, the cases, the confirmed cases, the location of the cases from this team. And then there was also a great collaboration, or trying at least to have a great collaboration between the communication team and the response team. And what was good also was the close collaboration with existing community network. So we already have a lot of community stakeholders, leaders already in our network. So we not only collaborate with them, but also support them as we could, not only financially, but technically, even material. So very quickly, so the role of those communication team, I talk about the approach we use. So the CATI approach, which is the centered area cases. So we targeted the area with cases, and we deployed the team on each confirmed cases. So what they will do, it's mass awareness, but also more targeted awareness in the neighborhood. And at the beginning, also they were responsible for the installation of hand washing. So all this education, the awareness around all in the neighborhood of the cases was under their responsibility. And again, in close collaboration with the community. And the response team, as we did in cholera, was responsible for, they supported the community surveillance very quickly. In Haiti at the beginning, when we have the two confirmed cases, people were they paid attention, but very quickly there were kind of disbelief. Most of the people will say there's not COVID in Haiti, especially because we had such grim prediction. And after 2 to 3 months, people didn't see so many deaths. So they started questioning the existence of the infection. But what those teams discovered on the field, why people were denying the infection, most people were reporting what they call the small fever, fièvre. It was everywhere in Haiti. So those response teams were, in the house, because they were doing home intervention, so information for the family, training the family for the family for disinfection, etc. They were also key to report the real situation on the field to allow us as partners and also the government to adjust the response. So that was mainly the work of these response teams. So what worked well, and it's very important for me to say that, because usually we say that the government doesn't do anything, sorry, but at this point we have to say that there was a kind of celerity of the MOH with part of the preparedness. They had their surveillance system set up for the, that was not perfect, but it was set up, as you mentioned, for Liberia, Joia, in the border, in several border areas. They already had the plan ready, and this plan was adapted from a previous plan we have for the flu since 2014. There was also this kind of spontaneous initiative in the community. People were not waiting for the government to come to them. People started in the social media, sensitizing people around the preventive measures. We have several people, small business, who put hand washing stations in front of their business. So that also was very positive. And the biosocial approach we try to use as much as possible for the response. So very attuned to the field, to what the community was saying, to adapt. So it was a kind of iterative process we use for this response. And also the fact that we use also the past experience, success stories to adapt to respond to this pandemic. There was also a good leadership of the Ministry of Health with a lot of imperfection, yes, but there was a certain good leadership in many departments, and many of the partners, the stakeholders, we were participating in the response. That could be the community leaders, that could be, the NGOs, the MOH members. Those people had already a kind of experience from, other epidemics like cholera. And so the good coordination also between the different teams. So that was also so many positive factors, elements that worth, to talk about. And also Haiti, use the example of our approach strategy to home care that as an example, that also was very positive. So in terms of challenges, very quickly, financing and coordination, we had a wonderful plan, I will say a very comprehensive and integrated plan, national plan, but that was underfunded. So when the financing part started, 3 months after, so most of the donors were, funding other stakeholders, let's say international organization, but also in the public sector, we didn't have the real actors with the right mandates involved in the implementation. So as a consequence of this, there were many gaps in the planning implementation, in the surveillance, in the laboratory, in the clinical care. So while we are trying to have a good surveillance at the borders, etc., but most of the department were not ready to receive patients because, well, they didn't have money to set up the hospital or the place for the patient. And at the beginning, there was a centralization of the testing at the national laboratory. Until GHD and Ballah started also doing the testing. But what happened is that there was not any fund for the national laboratory. And also in terms of, surveillance and response, there was an issue. We started the response. We tried to start as quickly as possible, but data were not available for the community responders. So there was also a large time lag between testing, delivery of tests, etc. We of course had under screening, and all of gaps, make it difficult for our team to respond efficiently on the field. And also community engagement, complex social political context, insecurity, as you know, in Haiti, you know, the political turmoil by this time make it very difficult to, and especially in some areas, you know, what we call the red areas, for our team to intervene. And the fact that, you know, the reality versus what they predicted make, you know, the population start questioning the real existence of COVID. So from all of this, we've learned that it's very important to engage with communities. They know when the government of the Asian government wanted to follow other country, especially rich country, by shutting down the country, people were saying, we are saying it's not possible in Haiti. It's not applicable in Haiti, especially in a survival economy. So it's very important to listen to people. And this is what we try at least to do. To adapt our response. The preventive measures like, you know, social distancing, put a mask, etc. We had to negotiate with that because it's very beautiful, but on the field, in a market, overcrowded market in Haiti, it's almost impossible. So we had to adapt and find another way to, you know, move forward with that. It is important to support national and local leadership, support local institutions. As we said, we know it. We said it. Functioning a health system is necessary to achieve access to good health. We need staff system. So again, we had the same issue with COVID that we had with cholera at the beginning that we have. So if we don't address that, we will be in the same situation every time. Timely and comprehensive intervention is key. We need a comprehensive package. So you cannot have the surveillance system ready and not having the response ready and not having the, let's say, the healthcare patient ready. So we need to be prepared and have, you know, a comprehensive package in order to be efficient. It's important also to not reinvent the wheel. Capitalize on what you have that will spare, and so you adapt, you innovate, but don't at each time reinvent the wheel. That will spare time, resources, and most importantly, that will spare lives. So it's important to harmonize the investigation and response process, and it's very important as partners, as government, to ensure funding predictability. So very quickly, Haiti is a case story. So one of the recommendations, is to elucidate, you know, the case story, the situation in Haiti. We know that wasn't under screening, but when you compare the several predictions, including national prediction, with what we have in the country, it's very important to come and analyze. We had at least 4 serology research that are underfunded. So that will be very interesting to go and make a better analysis of what we did, what are those numbers to use as an experience for the future. So to finish, I will say this program, especially for someone like me who always work with the UN nation, really help me remind myself what really matters, and also force myself to, even it's not always possible, but try to, as much as possible, to use the biosocial approach to the issues. So understand the social forces behind the current situation. So I will go every time I go further what I saw, for example, you know, why people are reluctant, for example, to the preventive measures, why people, you know, are, you know, more vulnerable here than, you know, in other places, etc., etc. That is very important. In some courses, all the classes were key there. So I will just name some of them. So, for example, Societies of the World gave us evidence that the global health work can be done in the lens of social justice. And that is very important to remind ourselves on the field, especially when we are, you know, facing those type of crises. And an ethnography class remind me or teach me the power of listening and observation. And that was also key for my work on the field in cholera, in malaria, managing the global fund, grant, etc. We need to listen to people. Because usually they will say that they don't know, we know better. And yesterday, I think you, Joia, mentioned that experts know better, but people, they know. So it's very important to listen, to observe and adapt to make sure that your intervention is really pertinent and efficient. And also so many skills also from other classes and negotiation, sorry, this is what I've been doing all the time. But what is important is, yes, you need to have a kind of win-win. It's a kind of win-win process. All the stakeholders has to win. The donors, because of my situation, yes, the government, etc. But what is important for me is to put the person in the center of all negotiation. And I will finish to say, yes, the program validated my goal of seeking social justice and provided me with tools to contribute to the work. So thank you.
Thank you so much, Phenide. I think that was another just great summary of how, your work in another part of the health system really led to your work on this pandemic issue, which was so complicated in Haiti and elsewhere. But in no place was it a pandemic that is exclusively a biological phenomenon. It's a biosocial, political pandemic. And I think, certainly the US response to COVID really shows the world how political health is. And many of you, and certainly the three of you, had to rise above the political challenges to really address not only the biological, but the social. So that sort of interface between the social forces at play and the work that we need to do to protect people and heal the sick is just always profoundly challenging. And all three of you managed to do amazing work during a very difficult time. So we have time. Would love to hear if there are any questions or comments from the many people online, many previous alum of the master's program, current students, potential students, and GHDI folks. So any comments or questions? If you raise your hand, I can open the mic, or we could just take them from the chat. And Byron is very appreciative of your shout out to ethnography. Byron, I didn't know if you're on the phone, but I thought I actually was going to give you a shout out when I saw that in the chat, but I've allowed you to talk. So if you'd like to add something, please do. You're on mute.
Hi there. I just want to say I've been driving to take Mary Jo to a doctor's visit, but I've been a bit in and out. But it's really wonderful to see my old friends from that class, to really hear of the wonderful work that you've been doing. And I just said, Phenide, it's a wonderful description of really like cuts to the very heart of what we think about ethnography, of actually listening to the voices of local people, going and being there, being present. When at the funeral for Paul, one of the things that I said is that he insisted on going there. Now, of course, you could talk about that in terms of accompaniment. As an ethnographer, the essence is going and being there and actually seeing with your eyes and seeing the situation. And so it was just wonderful to then say thank you, Phenide, for a shout out to that course.
Yes, and you are such a great mentor, I know, to many, including Lisa as a primary mentor. So thank you for all your support, and thanks to Mary Jo too, and I hope she's okay. When we think about implementation science. It's something we've been talking about in our department. And I think the kind of implementation science that we promote from this department is a very rich and somewhat non-traditional implementation science, but it really is to privilege the voice and the lived experience of the people who are the poorest. And it's a bit different than sort of looking at different kinds of data, but actually generating knowledge from talking to people. Because what I've learned from all of you as a non-social scientist is that, you know, there are methods of participatory work. And you know, it's, of course, I think I'm naturally good at going there, but I think what I've learned is that's also a scholarly pursuit. It's not only a moral one, it's both. Other questions, comments, if anybody would like to add anything, I'm happy to promote you to speak, or you can type your questions in the question and answer. Okay, well, we're up. Here's one hand. Who is that? Takes me a second to get to the hand. Stephen, how are you from Liberia, my friend? I'm going to allow you to talk. Go ahead, Stephen.
Yeah, good afternoon.
Good afternoon. Are you in Maryland?
Yeah, I'm currently in Maryland and sitting right in PRH office.
Right.
Yeah, thank you, Dr. Ballah. I've been following for the first time. And thank you for the intervention. I think the intervention have really helped in Maryland here. I currently work on the antimicrobial stewardship project, and having those meetings has really improved the health sector with the strategies that have been set up. So I hope you will continue the good work, that more engagement, that the partner support will continue. Thank you very much.
You're welcome.
Yeah,
Stephen.
Wonderful. And Stephen, thank you. Yes, go ahead. Go ahead, Elsie.
Yeah, just wanted to add, thank you, Stephen. Joia, you said something that, you know, that was not really seen in North America. When it came to Liberia, a lot of things were already put into place. And one of our successes was due to the system that was already set up from the time of Ebola. You know, that talks about to not reinvent the wheel, you know, but it is very important to use the existing structures that you already have. And then this was one of our successes. We use the existing structures that were so, you know, we could prepare easily for COVID. That was our success.
Yeah, and I wanted to thank Stephen for all your work during the pandemic in Maryland County, where what I saw when I was there with the team is that the structures that had been built for triage, the physical structures, the hand washing stations, the temperature checks that are before you get to the clinic were being used in COVID-19. So, you know, again, you could have looked at the Ebola as just get through the pandemic and finish, but actually systems were built. And maybe, Stephen, you can comment on how those systems in Maryland helped you with COVID.
Thank you very much. Thank you very much. So I'm Stephen Baker again. I'm a nurse professional, and I currently work for GSA as the antimicrobial stewardship, antimicrobial resistant focal person. And we are really involved with changing the issue of behavior change management, where people will make use of the microbiology lab and not just over-prescribing polypharmacy, making sure that we use what we call the culture and sensitivity result that will be tailored into patient treatment, which of course has been really, really working. I've been working along with Pacific. Pacific has been a student of the school. We have conducted normally war round to see how needed to improve clinical practice, because physicians around these days, like, oh, they learn this from school. So tailoring that treatment to what we call the culture result is very important. And also doing awareness that people will reduce the use and misuse of antibiotics around here. So like we conduct clinical war rounds, we engage physicians, we have regular meetings, look at the sensitivity pattern and see how we want to improve clinical practice. Yeah, as it relates to the question you asked, the team headed by Dr. George, and this was merely supported by Partner in Health. Partner in Health here is like a godsend. is like an angel to Maryland County. Yeah, they have been very much effective when it comes to health system management, building up the system. They help to construct that triage. And as we speak now, if you go to JJ Dobson, you see the environment is very, very good, conducive. They provide almost everything. So they are very much supported, like the consultants they have here, regularly looking at the COVID cases. And we had a system where they will do community entry, going to community to find case funding, and there was the awareness was ongoing, and they were much getting the case, and people were responding. And Maryland County approach was a very different approach, and this particular approach came from the support of the Ministry of Health, the MPHIL, and that of PRH. And with that, we were able to fight COVID, and we successfully defeated it. And I show the county have a very strong surveillance system team here that is headed by our DDSCO. Again, partnering health has been a very great help to this county, and we hope that they stay here for life. And I have a very interest in the global health program, though I applied it last time, and
Yes.
I got a mission letter, but I really know how the means to enter. I pray that I'll be part of one of the program, because I've been listening to Bartholomew Wosi, or how the friend here, Sarah Smith, including Pacific. These people are all we have been working together before, so I'll be here.
Well, thank you. Yeah. Thank you, Stephen. Yeah, we're always struggling for money, but we know you're on the list. This is going to be a tough year, just for everybody to know. We're hoping that we will have more scholarship money next year. So very, very great. I mean, in all of these cases, whether it's antimicrobial resistance, whether it's, Ebola, whether it's HIV, the earthquake, in each of these, in each of these iterations, if we build something more for the future, and we've always looked at, in the work that I've done for, quarter of a century, is when you're responding to a crisis, you got to respond to that crisis. But then you have to also look at what is the medium term and the long term thing that you can build, right? Okay. And I think in the medium term, the things that helped for COVID were building the systems. Obviously in the acute term, we're taking care of sick people. The medium term, building systems, like what Lisa was talking about, really from scratch. And then in the long term is hopefully, what Elsie was able to leverage, these existing systems, and that Stephen's talking about, that can then be sort of changed and pivoted to deal with the new crisis. So I think the hope for me, when we think about pandemic preparedness, is that we shift the dialogue away from the narrow focus on the pandemic to the stronger system at community level, at health center level, hospital level, and at the government level. And I think all of you really showed the strengths of doing a coordinated approach, the linkages with the past in some cases, and in the future. So, very much appreciate. Any other comments or questions? All right, everybody. Well, we can give you back some of your day. I want to thank these three amazing graduates of our program, Dr. Phenide Beaussejour, Dr. Elsie Ballah, Lisa Parvin, and our tremendous staff, Christina Bailey, our amazing faculty like Byron, Mary Jo, and others. It's such a privilege to learn from all of you and to see you go and make such a huge difference in the lives of poor people and in the communities you work. So thanks so much, everybody.
Thank you, everyone.
Bye. Thank you, Joia. Bye.